Good evening, everyone. We are so excited that you have joined us again for another of our webinar series. This evening, we are talking all about children that were born prematurely. We have an amazing panel with us as we give everyone a chance to log in. I know that people are coming from work, people are coming from different places. We'll give everyone a moment. I just want to tell you about a couple of things. You've heard me talk about them before, but I just want to plug them very briefly again. The first one is our podcast, our pilot podcast that we put out recently, a few months ago now. It is called The Stuff That Matters for Kids' Health. I host it. It's whatever you listen to podcasts, and we have so many of our experts who have joined the show. Just really incredible conversations. We also, as a reminder, are on social media. You can find us at Kids at Columbia on Instagram. You can also find us at Kids at Columbia on Facebook, and we have a newly launched LinkedIn page. It is Columbia Children's Health. And very briefly, I will also tell you before I introduce our wonderful panelists, I will also tell you that we have our Columbia Children's Health Gala coming up on May 6th. Follow us on social. We're going to be sharing details. It is just such an incredible evening and fundraising event that supports a lot of the work that we do in the Department of Pediatrics. So follow us on social. We're going to be sharing more. And with that, let's just introduce our amazing panelists that are joining us this evening. Super quick, I didn't introduce myself. I'm Dr. Edith Brachio Sanchez. I am a primary care pediatrician here in the Department of Pediatrics. I also do a lot of work in communications. This is work that I really enjoy, in case you can't tell. Let me introduce the amazing experts that we have this evening. So first, we have Dr. Faith Kim. She is an assistant professor of pediatrics here at Columbia. She's in the Division of Neonatology. Next, we have Dr. Kathleen Brennan. She is an assistant professor of pediatrics as well here at Columbia in the Division of Neonatology. She does so much to train the future pediatricians and future neonatologists in this country. We also have Dr. Sandhya Brachio. She is an assistant professor of pediatrics, and she leads the NICU Quality Improvement Program, as well as their NICU, as well as the NICU Growth and Development Clinic, which we refer to as the NICU Grad Clinic. We also have with us Dr. A Sanlorenzo, who's also an assistant professor of pediatrics here in our Division of Neonatology and co-directs the Bronchopulmonary Dysplsia Consult team. And all of these titles that I just told you about are going to come into play very, very soon as we start this conversation. So let's get right to it. I want to start with you, Kathleen, if that's okay. Just really wondering if you can ground us very briefly. I think we sort of say preemies, premature, and it's a term that most people have heard, most people are familiar with, but I always like to start with definitions and a grounding place. So how do you define prematurity? And perhaps most importantly for the conversation that we're going to have for the rest of the evening, how do you begin to risk stratify infants who are born prematurely, not just in the care that they receive in the NICU, but also in the care that they're going to need beyond that?
Thanks so much, Edith. Those are two great questions. Pregnancy is supposed to be 9 months, and so folks who are born below 37 weeks are considered premature, because they haven't had that opportunity to do the full growth and development that we expect in the womb, but instead are delivered too soon. And to answer your second question about how do we risk stratify, who are we most worried about? Some of that is exactly as you would expect, that the babies who are born earlier we're more worried about. So for example, the highest risk group is our extremely premature infants that are born at 22, 23, and 24 weeks gestation. But it also matters what happens in the NICU. So the sicker you are in the NICU, the more challenges you face there, the more we're worried about you, and the more that this wonderful team that's gathered here together is focusing on how we can help support the baby and the family.
Yeah. And, I also wonder, and this is also some of the work that you do, Kathleen, and you can tell us more about it. How do you set the tone with families? Because having a baby, as you mentioned, pregnancy is expected to last 9 months, and having a baby who comes sooner than that is a life-changing event, in some cases, in a lot of cases.
Yeah.
And tell us a little bit about the work that you do to set the tone, to have those conversations with families, and set the expectations, for what they're about to experience, and also for us in this conversation that we're having this evening.
Yeah. Another excellent question. And I think any of the group here could probably contribute to this. But one of the things that's really important for us is to think of all of our care, both in the NICU and beyond, as really shared decision making and shared care between the physician and clinician teams, our nurses, our nurse practitioners, our respiratory therapists, our physical therapists and occupational therapists, and everybody else, along with the parents and the family. And we all have to make sure that we're speaking clearly to each other about what our goals are and what our worries are, what our expectations are, and what we're trying to achieve in the next day, the next month, and beyond.
Yeah, it's that shared decision making, right? That you all do so well, and that we try to continue as pediatricians when babies then come to us. Before we move on and include the rest of the panelists, I also want to ask you about another area, Kathleen, that you're very, very qualified to talk to us about, and that is nutrition.
Mm.
What are really the nutritional requirements? And I know that I'm asking you a huge question, but I wonder very briefly if you can walk us through the nutritional requirements for infants that are born prematurely, how they're different from full-term infants, and how do you determine the best approach when babies leave the NICU?
Thank you so much for asking that question. As you know, and as so many of our pediatricians on the call will remember from their time training in the NICU, a huge area of our focus is about nutrition and about growth, because of course we know that affects development as well. So in the NICU, most of our babies have missed some or all of that third trimester. And a huge focus of the development in that third trimester is gaining weight and gaining micronutrients like calcium and phosphorus. And so those are really our areas of attention when we are trying to simulate what moms do so beautifully if the pregnancy carries to term. We're really focused on extra calories to allow for that growth and focusing on those micronutrients to allow for good calcium and phosphorus delivery and good bone growth. And then we continue those same principles once babies are born, once babies are in the NICU, and once babies go home. The same principles really apply all throughout those 3 stages. But of course, we know that every single baby is different. Every baby is unique, and everybody is going to have unique needs. Some babies might be breathing faster, and therefore they're burning more calories. We have to take that into account. Other babies might not be breathing as fast, and so they might not be burning as many calories, and we have to take that into account as well. So one of the things that we really try to partner with our amazing community pediatricians at that time of transition home, and of course with our families, is to think through what are the nutritional needs of this unique individual, and how can we follow that over time to adjust to something that of course will be evolving and changing over time.
Yeah. I love that. And it's that partnership that I think goes such a long way, right? With the parents, with the community pediatrician that's following the child. And, there's also something that you said in passing that I find fascinating and intuitive. And it's that nutrition is key in the developmental outcomes. Just say a couple more words about that.
Yeah, thank you so much. There's been really a tremendous amount of work done to understand that relationship of how healthy growth can affect neurodevelopmental outcomes in particular. And the overarching theme from the literature and from the most recent Cochrane reviews and meta-analyses is that with appropriate growth velocity, right? So growing appropriately over time, rather than a specific weight or a specific height. It's that growth velocity over time really does tie nicely to better neurodevelopmental outcomes. And I suspect we'll hear lots more about that from Sandhya and Faith and Lauren as we continue. But that's really what we're talking about. And so it's really important as we, as clinicians, are reading that literature to be thoughtful about what the criteria are and really not focus on a weight so much as that growth velocity or weight velocity over time.
I love that. I love that. And very helpful for the primary care pediatricians, right, who are sort of looking and knowing what to look for.
Yeah.
As a reminder for everyone who's watching, first of all, thank you again for logging on and spending this evening with us. But for everyone who's watching at home or in transit, just to say that you can type your questions into the Q&A. We will be looking at questions as we go. We'll try to incorporate them, and then we're also going to save time at the end to answer additional questions that come up. But please, please, please feel free to drop those in the chat. I will be looking throughout our conversation this evening. So I wanted to move on now, Faith, and we can definitely come back to nutrition as questions come in from the chat, and I suspect we may have some. But I wanted to move into talking about developmental outcomes and developmental surveillance specifically, right? So in general, just to start with sort of the general and the guidance, how do you approach developmental surveillance in children who were born prematurely? And I'll go to you, Faith.
Thank you for that question. I think I'm lucky to be a part of a group here who have the opportunity to follow our preterm babies as an outpatient as they continue their journey once they leave the NICU. And most NICUs across the country will have something like a high-risk infant follow-up clinic or a neonatal follow-up program. We are lucky to have the neonatal growth and development, or the grad clinic, and we follow babies who are born prematurely, a subgroup of them, or any babies that are at risk for neurodevelopmental impairment. And it sort of depends on the age of the baby, but over the first 2.5 and 3 years, in the earlier age groups, we're able to start doing sort of screens for motor conditions like cerebral palsy, which our preterm babies are at risk for. And as they get older, we're able to do more developmental assessments to really look at their sort of language development. We're lucky to have a developmental and behavioral pediatrician, Dr. Paskin, who's been on your panel before, and a clinical psychologist, who are then able to really look for other sort of neurosensory impairments and conditions, particularly when we think about behavioral things like autism and ADHD. And so they're able to provide screening, testing, and even giving diagnoses of those as our babies get older and grow with us. And beyond sort of describing their development, we're then able to sort of tailor how we can sort of guide our parents in terms of implementation of services, whether it's interfacing with early intervention or trying to advocate for more services like physical or speech therapy, things like that. And so we're able to really provide that co-management with our families as well as our community pediatricians.
That's great. Faith, a couple of sort of logistical questions, and then a question that just came in the chat. Who qualifies to be followed in your NICU grad, as we refer to it, clinic? And yeah, I'll ask that first.
With time and growth of the clinic over the past few years, I'm actually sitting next to our director of operations, Sylvan, who I know you can't see, but has played such a huge role in this. We were actually able to broaden our criteria. So we see preterm babies that are born less than 29 weeks gestation. We also see any baby with a birth weight less than 1,500 grams, because we know from the literature that even if you're born older, but you are smaller, going back to that nutritional piece, we will also see these babies in our clinic. And then any baby who has any sort of condition or brain injury that could affect neurodevelopment, we will also see those babies. And so babies who've had a stroke or birth asphyxia, complex cardiac conditions, those are all babies we will see. And really, if there's any concern, even in the NICU, if they don't fit that criteria, but perhaps one of the providers or our physical or occupational therapists who see our babies, if they notice something on their evaluation that strikes them to say, perhaps this baby needs closer surveillance, in addition to obviously seeing the pediatrician, we will also bring those babies to our clinic and do developmental surveillance.
Yeah, great. Faith, do babies have to have been born in our system and been in our NICU to be followed in the NICU grad clinic?
It's a really great question. I would say that the majority of our babies that we see here in our clinic were born in our NICU, but we have actually had pediatricians refer babies from the general pediatric floor if they had some sort of brain injury or an infection like meningitis. We've also had families whose babies were born in NICUs all across the country, but perhaps they're relocating to this area. And so we will sort of pick up where the last follow-up clinic left. And we have been able to implement sort of an early cerebral palsy detection initiative the past 2 years. And so we've had a few families from around New York, New Jersey, Connecticut, who've reached out to us to come to our clinic to get the screening tools that we provide here as well.
Yeah, that's amazing. That is amazing. And hopefully something that pediatricians who logged on tonight heard. Now, a couple questions that came in the chat. Is there a formal screening tool that you use to screen for cerebral palsy?
That's a great question. I don't know who planted that question, but we are very lucky to have the support of the Cerebral Palsy Foundation. And so we were able to really implement the tools that are part of a pathway that was established by an international, expert panel in early CP or cerebral palsy detection. And so starting in 2022, we rolled out our initiative and we use 3 specific tools. So one is the general movement assessment, where we're able to provide a video recording of a baby throughout stages of their early motor development. That gives us a sense of sort of their CP risk, starting even in the NICU. We also use a standardized neurologic exam called the Hammersmith Infant Neurologic Exam, or the HINE. We were grateful to be trained in that a few years ago, including our therapist team, and we're able to provide that longitudinal assessment to our babies in our follow-up clinic between the ages of 3 to 24 months. And then we also use a standardized gross motor assessment known as the Alberta Infant Motor Scale. And that might be more familiar for people who interface with early intervention, because it's typically the assessment that the physical therapist will use to help guide them to sort of risk stratify a baby's gross motor development. And so with all of those tools in place, along with a good clinical history, a good exam, and this sort of surveillance over time where we can look at these tools at multiple time points, we're able to use all of these sort of key elements together to diagnose our babies with CP earlier, with the hope to get them into intervention earlier.
I have to tell you, I know that you guys exist as a team. I know that you guys are amazing as a team, but hearing you talk about these initiatives and the way that you screen and monitor babies it's really amazing to understand and to get to hear about. So just a quick comment on me, on my part, to say that it's really amazing to learn about, how thorough you guys are. Let me ask you one other question that came in the chat. Is there a gestational age that automatically qualifies a baby to receive services through early intervention?
I might pass that baton to Sandhya, who is the expert in that. I think we have worked a lot in terms of the automatic qualifications for early intervention. And I think we could probably have an entire panel about that in and of itself. But I believe one of the automatic qualifiers is a birth weight less than 1 kilo, but not necessarily a gestational age.
Yeah. Sandhya, feel free to weigh in if you'd like.
Sure. So We have done a lot of work locally to see how we can best partner with early intervention within New York City, in New York State, and even in the tri-state area, because we have patients from all over who receive their care in our NICU. And early intervention is a federally funded program, but it is on a state-by-state basis how qualification is determined. So things are slightly different in New Jersey than they are in New York State or in Connecticut. But New York State has certain auto-eligible diagnoses, one of which, as Faith mentioned, is a birth weight less than 1 kilo, 1,000 grams. And so what we have done from the NICU is to help our parents who are in the NICU as their babies are leaving, to help them advocate for their children to so that when early intervention reaches out to set up an evaluation for their child after the baby is discharged from the NICU, that we equip them with the discharge summaries and to say, hey, when they call you, make sure you mention that your child, your baby has an auto-eligible diagnosis. What that means for early intervention in New York is that then the child automatically qualifies for some services. What those services are varies based on the borough in New York City, the county in New York State. And so there are many factors that go into that. But the biggest thing we try to do in the NICU is to help families be advocates for their babies and to say that, that partnership that so many of you have mentioned continues. We as the NICU grad clinic want to partner with the families, with the community pediatricians to say, how can we get a patient, even if they may not have an auto-eligible diagnosis, who we may have concerns about developmental delays, how can we get them access to the appropriate resources, whether that is advocating through early intervention and setting up an evaluation that way, or finding other methods of providing therapies for the baby.
Yeah, amazing. I did want to ask you, either Faith or Sandhya, a follow-up question about development in general. And I just wonder, we focus a lot on developmental milestones and developmental delays. And we just talked about cerebral palsy and what you all do to screen babies. But what other conditions are babies who were born prematurely at risk of developing? And specifically, I'm asking about neurodevelopmental conditions. And either one of you feel free to answer this question.
I can start off. I'm sure there's more to say, but like I mentioned earlier, in the earlier stages, we can provide the sort of gross motor sort of screening tools and assessments, specifically looking at sort of the risk of CP. But then we do know that our preterm babies are at risk, particularly for language delays. And so as they get closer to that sort of 1 year corrected mark, then we do switch to a different developmental assessment called the Bailey, which our clinical psychologist is able to administer. And then we can start to really assess for expressive and receptive speech delays. We know our babies are at risk for visual impairment, hearing impairment, particularly in the preterm babies. We think about retinopathy or prematurity. And so our ophthalmology team works so well in our NICU to provide the appropriate screening. And we're here on the outpatient side to really sort of reinforce that anticipatory guidance that the pediatricians are doing with the family and the ophthalmologists. And then there are new guidelines that came out recently about sort of hearing evaluations and screenings outside of the NICU. And so we also follow those in the outpatient. And we were lucky to partner with one of our other neonatologists, Dr. Good, who really is an expert in the kidneys, and joined forces with the renal team with the knowledge that our preterm babies are also at risk for chronic kidney disease. And so they actually have joint visits when the baby is about 1 year corrected with our renal doctors as well. And so the different sort of conditions we screen for do change over time. And then again, in the older babies, we will, similar to you all, we will administer the MCHAT to start to screen for autism in the older population. And again, really provide sort of that reinforcement along with everything that you guys are doing in your clinics.
Yeah, perfect. I wonder if you could say a couple of words, and again, knowing that I'm asking you a huge question, what do we know about the risk of autism spectrum disorder in babies who were born prematurely, and what do we know about the risk of ADHD and learning disabilities?
I am not sure I am the best person to give sort of the
Yeah.
quantifiable risk beyond knowing that there is an increase for both of them in our preterm babies. But I rely heavily on Dr. Paskin and Dr. Zygmunt, knowing that that risk is definitely there. But the quantifiable part of it, I'm not sure I am the best person to answer that, to be honest. If anybody else wants to chime in.
Sure. I think, yeah, the quantifiable risk is tough because as we learn more about developmental development in general over time, we're learning more about autism, we're learning more about ADHD. But what we do know is that, even though a child may have a particular course in the NICU, that could have an impact in the long term. And so that's why we always think about it as a NICU journey, and why it is important to follow that development over time. We as neonatologists are very focused on that early development, and Kathleen and Faith and I and a few others in our NICU grad clinic are seeing the younger patients, and so can screen for those types of delays that Faith had spoken about. And then as they get older, Gabby Paskin and Annette Zygmunt, our developmental behavioral pediatrician, and our developmental psychologists are screening and ensuring that children are transitioning from that early intervention stage to how are they transitioning into preschool? How are they interacting with other children? What type of social skills are they developing from that standpoint? And then there are some times that we follow even further into how are they transitioning from that preschool age to now school age. Are they in an appropriate environment in the school? Are there any extra resources that we need to be thinking about? And again, that partnership is something that our community pediatricians have so much on their plate in terms of the well child visits. And so we try to help with that in terms of assessing for all of those other kind of areas that might be impacted by a prior NICU stay. And the other things that we didn't really touch upon in terms of risk, sometimes we have children, we've talked a lot about neurodevelopment in terms of social skills and motor skills. But sometimes there could be feeding challenges that babies who are born preterm might have in terms of needing, not just the nutrition that we talked about, but are they appropriately transitioning from a milk to oral foods, or is there some sort of oral aversion that might be developing? And if that's the case, we rely heavily on our speech and language pathologists, who are so integral in the feeding, and then later on speech therapy as well. And so lots of things to think about. And so again, it's a longitudinal assessment that we're doing with the families, with the community pediatricians, to make sure that children are growing and developing as the best of their abilities.
Yeah, and I think you just answered a question that just came in the chat about touching on the developmental effects of, or the developmental journey that is related to feeding and feeding participation and feeding safety. The specific question that came in is whether you guys in the NICU use a preventative approach to stratify and to help babies, knowing that there is risk for feeding disorders, aspiration, depending on the abilities and the specific case of the child. I think the answer to that is yes, you guys are very preventative, but is there anything else you'd like to add, Sandhya?
I mean, our NICU nurses are absolutely fabulous in gauging when babies are beginning to show cues for wanting to start feeding by mouth. And so often babies who are born preterm might not be able to feed at the breast but with a bottle from the get-go, and might rely on a feeding tube to be able to give some of that nutrition. But around when they would be 33, 34 weeks, we start to see some cues, just as that neurologic maturity progresses, that a child is going to want to be able to eat more by mouth. And so that's where our NICU nurses and our parents are, integral in helping the baby kind of eat. And we always say, the baby's the boss. We're going to let them kind of lead the way. And today, the baby might take 10 milliliters by mouth, and that's a success. And then tomorrow it might be a little bit more, or we might go back and forth. And so we are consistently assessing the baby's readiness to be able to feed safely by mouth. And if there are concerns that do arise, we also have speech and language pathologists in our NICU who can then stratify in terms of, does the child need a specific type of nipple? Do they need to be held in a certain position? Do they need to be paced in a certain way? And we're working with our families so that by the time the baby is leaving the NICU, the families are feeling confident in their ability to safely feed the baby at home, so that you don't need to be connected to monitors and can continue to follow with the community pediatrician in terms of their overall growth and development.
Yeah, it's all a journey, and the baby, I love the way that you put it, the babies really are driving the interventions and what's needed, what's not needed, what's appropriate. Now I do want to transition to talking about, we're hitting huge topics today, but talking about the lungs, because we know, as pediatricians and the parents who are joining this call have probably learned that we worry a lot about lung development in children who are born prematurely. So Lauren, I want to go to you because this is your area of expertise. And I wonder if you can start by telling us how you and your team risk stratify babies in terms of their risk for developing chronic lung disease of prematurely, BPD. I wonder if you can talk a little bit about that.
Yeah, absolutely. Thank you. So bronchopulmonary dysplasia, or BPD, is the term that we use to describe lung disease that results as a complication of preterm birth. And it's seen, we know, in some, but not all infants who are born less than 32 weeks. And it's a disease that really affects lung tissue, the airways, and the blood vessels, all of which, contribute for the normal functioning of the lungs. And so it's very complex, and it's sort of one term, and yet it's really a very different disease process in individual babies. And we know that right now, the best way to stratify the disease into the equivalent of essentially mild, moderate, or severe would be for the neonatologist to assess the infant when they reach that 36 weeks corrected gestational age, and determine the severity based on the level of respiratory support that the baby is receiving. So we can sort of say that if the baby at that point is on room air, that they don't have BPD. And if they're on low flow nasal cannula, that they have mild or grade 1. And then we know for babies who are still receiving, commonly in our NICU, CPAP or other forms of non-invasive positive pressure, that they have moderate disease. And then for babies who are still receiving invasive mechanical ventilation at that time point, we know that they fall into the most severe category, and that's sort of often described as grade 3 or severe BPD.
Yeah, great. And super helpful for those of us who are a little bit removed from being in the NICU to sort of go back to the basics of what the disease process is, right? And how you think about it. I wonder, often when I get a child, right, in my practice as a primary care pediatrician who was born prematurely, you guys have done that work. There's often a pulmonologist who is involved. How are we helpful as primary care pediatricians, and what is sort of our role, Lauren?
Yeah, I mean, it's such a fun privilege as a neonatologist to then go on and partner not just with the pulmonologist and sometimes the cardiologist that focus on the vascular disease associated with BPD, but then also the medical home and the primary care doctor. And I think the medical homes and primary care pediatricians have a huge role to play in caring for infants with bronchopulmonary dysplasia, because families need to understand that for some children, it's lifelong, right? The implications of the lung disease related to prematurity. And so I always think about starting at the basics with things like vaccination, and helping parents understand the risks that are associated with respiratory viral illnesses in children with BPD. So thinking about how to have a conversation with families about respiratory symptoms like cough and wheezing, difficulty with endurance or exercise. We know that infants with BPD are at high risk for sleep-related problems. So thinking about frequent waking at night and different sleep-related issues. And then I think, one thing that we all strive to do is to stay well connected. And so that it's not fully siloed, like I only took care of them while I was in the NICU and the pulmonologist is in their own office, but to think of us as like a real collaborative team that's willing to continue to meet and think strategically about the infant, especially if their course in the outpatient setting is challenging or more difficult than better.
Yeah, super helpful for us to be thinking about that, Lauren. And I wonder if you can also touch on the risk, and this is separate from BPD, or at least the way that I'm thinking about it is separate from BPD, but please correct me if I'm wrong. But I wonder if you can touch on the risk of wheezing with viral illness and what we refer to as reactive airway disease in babies who are born prematurely, but perhaps don't have a diagnosis of BPD.
Right. Yeah, we know that in the first 2 years of life, after leaving the NICU, infants with a diagnosis of bronchopulmonary dysplasia are at increased risk of wheezing with viral illness, and they're at higher risk of having hospital readmission for respiratory causes compared to their premature counterparts who did not meet criteria for BPD. And we know that that risk really increases with the severity of disease. So there's lots of epidemiologic papers that help us understand that it's like 1 in 5 babies will have more than 2 admissions in those first 2 years of life if they have grade 2 BPD, and 1 in 3 babies will have more than 2 admissions in those first 2 years of life if they have the more severe or grade 3 BPD. And then additionally, a lot of children, like lots of papers show us that more than 50% of kids with severe BPD are using inhaled respiratory medications at home. And so the prevalence is high of wheezing and obstructive symptoms. And so identifying them, asking about them, and then either connecting them to a pulmonologist or following closely in your own capacity in the primary care office is very important.
Yeah, great. And what about the babies who don't have BPD? But were still born prematurely? Are they at risk of wheezing with respiratory illnesses?
They are, certainly they are, right? Because again, there's a real limitation to our diagnosis, right? We're talking about the diagnostic criteria focuses on one day and time really in a full NICU journey. And so we always want to be mindful that even if you are getting a baby in your clinic who, had a really great NICU course, had great growth, didn't have a lot of the typical complications and did not have a diagnosis of BPD, is still at increased risk compared to a term infant of having challenges dealing with sort of common viral illnesses in infancy, specifically those first 2 years.
Yeah, perfect. And related, we'll talk about that in a minute. But of course, we'll talk about vaccinations. I saved it for last. But I do want to touch as we're going sort of around and thinking about the different systems and different ways that we think at the end of the day comprehensively about babies who were born prematurely. I'd love to talk next about the heart. So Sandhya, I'll go back to you. How should we, and again, I'm asking you guys sort of big picture first, but how should we think about the heart of formerly premature infants?
So for the most part, if when a baby is leaving the NICU, if they have not had any major concerns in terms of their blood pressure as we're monitoring their blood pressure or their different lab values that we're checking, how they're breathing. For the most part, a premature baby is not going to need an echocardiogram, an ultrasound of the heart, automatically just because they were born preterm. There are some cases where we might get that echocardiogram while the baby is in the NICU for any of those reasons that I had mentioned in terms of concerns with how they're breathing, concerns with we might be hearing a murmur, we might be concerned about their blood pressure, we might be concerned about BPD. So there are certain things that might prompt us to get that echo. And most often what we see are sometimes there are connections that are present in the heart that are necessary when babies are in utero, but they can be persistent after the baby is born. And sometimes in preterm babies, things we call a PFO or a PDA, patent foramen ovale or patent ductus arteriosus. These are things that are necessary for in utero circulation, but we don't expect to see them remain open after a baby is breathing, outside of the uterus. And so if those connections remain, then we might recommend at NICU discharge that a baby should be followed in the long term by cardiology. But for most babies who are born preterm, we don't necessarily need specific cardiac follow-up on NICU discharge. The caveat for that would be, Lauren had talked a lot about BPD. And so for children who are on breathing support, when they reach that 36-week mark, we have a standard that we automatically get that echocardiogram looking for other changes that we might see in the heart that might be related to how their lungs are developing that could affect their heart. And so those might impact how we think about the baby in the long term. And we do know, as you said, all the organ systems are related to each other. And Faith had mentioned Dr. Good, who is one of our neonatologists who focuses on kidney development in preterm infants. She has helped us partner with the nephrology clinic so that when children, preterm infants, are coming to our NICU grad clinic, we are referring them to the nephrology clinic because the kidneys affect blood pressure. And high blood pressure can affect the heart. And so all of those things are connected to each other, but that's how we're thinking about it. But most often, if a baby is born preterm, that does not automatically mean that they need cardiology follow-up when they leave the NICU.
Perfect. Let me ask you more about blood pressures. As you know, we don't really regularly screen blood pressure or high blood pressure in infants that come to primary care who were otherwise not born prematurely, right? So I want to be, I'd love for you to clarify who needs true blood pressure screening, and really just for us as primary care pediatricians to be on the lookout and know which baby we need to be screening.
Absolutely. And so this is something that we have thought a lot about because we see a wide range of patients in our NICU grad clinic. And the patients that we are most concerned about in terms of that long-term surveillance are those babies who are born less than 1,500 grams and preterm. And so we want to make sure that their kidneys are developing adequately and that that's not affecting that blood pressure in the long term. So how we think about it in our grad clinic is that the first visit happens when the baby is 3 months adjusted age, which means 3 months from their due date. And so at that time, we're not checking a blood pressure. But what we're saying at that time is, hey, just like we're thinking about the long-term development, next time you come to see us when the baby is 9 to 12 months adjusted age, we're going to send you to the nephrology clinic where they're going to check the baby's blood pressure and they're also going to check the baby's urine to see if there are any signs or concerns that the kidney development needs to be monitored more closely. And so I think in terms of the community pediatrician, I would think about definitely the babies less than 32 weeks or babies with a birth weight less than 1,500 grams, thinking about around that 1 year visit to think about if they are not been connected with a nephrologist through a NICU grad program or anything like that, to think about screening for blood pressure or even sending to nephrology at that point.
Super, super helpful. Let's go back, Lauren, to talk a little bit about vaccines. Because, again, we're talking developmental outcomes, we're talking nutrition, we're talking heart, we're talking lungs. It's really so important to protect. all babies really, but even more so babies who were born prematurely. So what are those key vaccines you're looking for? And you really need the partnership of community pediatricians and parents to hopefully feel confident in their decisions, and not miss.
Yeah, absolutely. And one thing that's such a gift of being a neonatologist is that the families are often, they're so engaged during that NICU course, and they have trusted us with so many invasive things in caring for their infants. And so when it gets time to talk about vaccines, families are normally seeing that, I think, in the neonatal setting as an opportunity to talk about the things that they were anticipating talking about their children in sort of a routine setting after a presumably term delivery. So what's super important? We know from the AAP that recommended childhood vaccines should be given on the standard schedule when the child reaches the age at which the shots would normally be given to all children. So for us in the NICU, that means when a child reaches 2 months of age, even if they're not yet corrected to term or near term, we are working to vaccinate them at that 2 months of age, 2 months of life time point. And then we hope to carry on that sort of standard schedule as an outpatient. For hepatitis B, we have some modifications such that babies who are born less than 2 kilos and premature, we work to give the hepatitis B vaccine at 1 month of age or at the time of discharge, whichever one comes first, and then carry that schedule on as an outpatient. And then, of course, we know that some of the more seasonal vaccinations like influenza vaccination, COVID vaccination, and RSV vaccination is very important for this population. So this year in our, world and our NICU, we were using Beyfortus, which is recommended for all infants who are younger than 8 months of age when they were born during or entering their first RSV season. And so that was like a really exciting thing to be a part of this year in vaccinating babies as they left the NICU.
Yeah, amazing. And I think it's something that all pediatricians were really excited about. So we're talking about the RSV immunization. We don't really call it a vaccination because it's a monoclonal antibody. But really just how amazing it is that we have this tool now. It's amazing for all of us as primary care pediatricians. I can only imagine how excited you guys were as NICU doctors, to be able to protect children against RSV, which we know affects so many children every year. So I do, I did want to make space, and this is sort of the last question that I have, and then we can definitely turn to the questions that are coming in the Q&A, and everyone listening, please feel free to send us your questions. This is the last question that I sort of had prepared, but Sandhya, I want to go back to you because there's a lot that when we're talking about the medical management, we don't always talk about front and center, and that is the social and the emotional needs that come up, and we know that those have a huge impact on the outcome of a child and the family as a whole as well. So I wonder, what do we know about current rates of postpartum depression in moms who have babies who are born prematurely? And then also, what do you do as a team to try to help this?
It's a great question. Thank you so much. So we do know that rates of postpartum depression and actually postpartum mood and anxiety disorders are occurring at higher rates in birthing parents of babies in the NICU. And one of the things that we have been fortunate to be able to do in our NICU, and this was under the leadership of another one of our colleagues, Dr. Sinead Brady, who helped rewrite the AAP guidance that looked at longitudinal screening for postpartum depression, because the AAP is recommending that this is done at every well-child visit, right? When a baby is admitted to the NICU, they may be there for many months if the baby is born at 22, 23, 24 weeks. And so they might miss some of those well-child visit milestones. And so one of the things that we have worked to do in our NICU is to think about how we can standardize that screening for families within the NICU so that we can connect parents with appropriate resources. And I think it's important also to note that we think a lot about postpartum and the birthing parent when we think about these mood and anxiety disorders, but the other parent is also at high risk. Being in the NICU is a stressful time for a family. It is not the expected bonding pattern that, you might have anticipated during the pregnancy. And so there are many stressors that are associated with that. And so one of the other things that we were mindful of doing in terms of screening for depression was to include the other parent as well, and also found high rates of positive screens for depression. We are lucky that we have 3 fabulous social workers and wonderful care managers. Our social workers are really, even though we have these timelines for screening, they are constantly meeting with our families and ensuring that families are connected to appropriate resources, whatever that might be in their community. And we have also reached out to other community agencies like the Motherhood Center and many others to be able to provide our families with mental health resources. We had talked about screening in the NICU. In our NICU grad clinic, we have also made sure that we are screening for postpartum depression or for depression with the patient health questionnaire, which is also used in our ambulatory care networks clinics. And so we are doing that as well, and also partnering with community agencies to provide families with the appropriate resources.
Amazing. It's really such a team effort, right? To make sure that the families, as this life-altering event happens, right, or life-changing, are able to feel confident and ready to take care of their little babies as they're leaving the NICU, as they're in the NICU, and then later leaving the NICU. So we just had a bunch of questions come in, which I'm really excited about, because it means that people are engaged this evening. So let's go through them. We'll do sort of a rapid fire. Hopefully we can tackle as many of these as possible. So I'll start with you, Kathleen. There's a couple of questions that came in around nutrition. The first one is, are you still targeting 120 to 140 calories per kilogram? Is that still sort of the general wisdom, knowing that every child is different?
Yeah, that's exactly right. And I appreciate the questioner giving that range, but because of course that's how we're adapting to each individual patient. But it's not just the calories. We're really looking at what effect the calories have. And so what is the weight gain? And we're really, the AAP says that we're looking for 20 to 40 grams of weight gain per day in that 3rd and 4th trimester. So that 3 months after we hit term.
Great. There also was a question that came in, and now I'm not finding it, but I think I remember what it was. Is there specific nutrients or specific things that you sort of recommend people look out for?
Absolutely. So a couple of things. One, I'm so grateful to our amazing dietitian, Natalie Koo, who put into the chat that, of course, some of the things that we're going to be paying attention to are sodium intake, because low sodium in the blood can delay growth. And so we're focused on that. Calcium and phosphorus we talked about already. And along with that, of course, goes vitamin D, all really thinking about that healthy bone growth that all infants need, but particularly our preterm infants who didn't get as much of that good bone growth in that 3rd trimester. And then thinking about just calories in general, really wanting to focus on that increased caloric intake in the 12 weeks right after discharge from the NICU is the current AAP recommendation. And so that's why we do fortification in those first 12 weeks and then adapt based on the growth that we're seeing of the unique individual.
So it sounds like you just answered the other question that came in, which was, what's the criteria for giving 22 kcal formula after discharge from the NICU? And it sounds like that's the AAP criteria for it. And at what point do you switch to 20 kcal? And it sounds like after that time point, if the baby's scoring well, and you don't need to adjust.
That's exactly right. In particular, they're looking for us to have a baby that is above the 10th percentile. That's the AAP cutoff for needing to come off the 22 calorie. But we know that, of course, that doesn't capture everybody. We have babies who grow small because their parents are small. And so perhaps that 10th percentile doesn't fit them. And so taking, of course, all these recommendations in the context of the family that you're caring for.
Perfect. When it comes to solids, are you introducing based on the age, chronological
Yeah.
age, corrected age, development? What are you using to guide your introduction of solids?
That is such a great question. We typically use the chronologic age, like vaccines. So the around 4 to 6 months of chronologic age is when we're starting to think about those solids. We typically tend to say 6 months for these babies in particular is the safer course because of all of the dysphagia concerns that have been brought up already earlier today.
Amazing. Faith, going to you, when you are using the MChat, the tool that we use to screen for autism spectrum disorder, do you use chronological or corrected age?
We, for most things for premature babies, we will use their adjusted age until they're 24 months, and then we will convert to chronologic. So we usually, I believe at our 18-month adjusted visit is the first time we typically offer our MChat for our babies.
Great. And then we just had a question come in. What are the tools that can be used to diagnose autism if seeing a patient for the first time past the cutoff of 2 to 3 years?
I know based on my observation of Dr. Paskin and Dr. Zygmunt, they will really rely on their clinical history and their direct observation of the baby and the family, and they're just so attuned to that. And so they've been able to provide diagnosis of autism really based on their evaluations in our clinic alone. I know Dr. Paskin will use some other assessments like the CARS assessment. I know that there are other developmental clinics that will use things like the ADOS, which is sort of a longer assessment, but just given their expertise alone, I've seen them be able to really pinpoint that diagnosis even in their sort of first initial interactions with the baby and the family.
Great. Lauren, we just had a question come in about rotavirus vaccine. Why is it not given in the NICU?
Right, because vaccine-derived viral shedding is common or routine following rotavirus vaccination, and because of the theoretical risk of transmission in the NICU, most NICUs, but not all, because there's many studies that have shown relative safety, but for the most NICUs, we're not giving that in the NICU.
Yeah. So because it is a live vaccine, you could shed some virus after you receive it. So that is why it is not given. We also had a question come in. It sounds like from a parent about it may have been, oh, I lost the question. Where did it go? Transcranial ultrasounds. Do you do them on all babies? Who gets a transcranial ultrasound in the NICU?
Routinely, all babies born less than 32 weeks gestation have ultrasounds, and then other infants can qualify if they have abnormal movements or if we're concerned about any intracranial process.
And then we have someone who works in early intervention. Thank you for joining this evening. I wonder if whoever feels comfortable can talk a little bit about reflux and how common it is in babies who are born prematurely and sort of their digestive tract in general.
I am happy to take that, but of course I welcome my colleagues to jump in at any point here. We see reflux very, very commonly in preterm infants. We know that preterm infants have slightly lower tone overall, and that seems to correlate with that upper esophageal sphincter tone as well. And so many babies have reflux. Premature babies are particularly prone to reflux. And for the most part, the same rules apply. If that reflux isn't influencing growth, if there isn't severe arching, if there isn't an impact on the vocal cords and inflammation around the vocal cords, it typically doesn't need medication therapy. And we're, of course, balancing that risk of medication therapy, which can decrease the acid, but not change the fact that the reflux is still happening. So it might help with discomfort, but it doesn't stop the reflux from happening. And yet it can lead to higher rates of infections. So trying to balance all those things together in concert with how the baby is doing, how comfortable the baby is. And that's where we have to really work with families and pediatricians. know what the right move is.
Great. And the context. So that question is that a lot of babies are not doing or not tolerating tummy time well because of reflux. So I do appreciate you sort of giving us that context, Kathleen. And believe it or not, we answered all of the questions that came in the chat and got to all of the questions that I had this evening for you all. It really was such a pleasure. Thank you. I know you are all very, very busy clinicians and do a million of other things. So we really just appreciate you taking the time to join us and sharing your expertise this evening. We appreciate everyone who signed in live for this webinar. It is also going to be available on our YouTube channel, YouTube channel. And please, and we'll send the link on the email that we usually send after webinars to recap. And then please follow us on social media so you never miss one of these webinar announcements. We're on Instagram, Kids at Columbia, Facebook, Kids at Columbia, LinkedIn, Columbia Children's Health. And we hope to see you on May 14th. We're going to have our next webinar. It is going to be on asthma, and we're going to be sending the details out very soon. May 14th, mark your calendars. Thank you all so much for joining us this evening, and we'll see you next time.